I'm really probably going to mirror a lot of what Paolo has said, but actually be able to tell it to you from a patient perspective, and also the mistakes I made as a patient, and where Paolo has confirmed perhaps I wasted resources earlier on because of physiological concerns.
Slowly.
Do I have time to speak slowly?
Yes.
I am worried about time. Okay. So this is really a patient's experience of testing and view on prognostic predictive testing, and a little bit about how that's influenced my treatment since diagnosis. So I was diagnosed with CLL 10 years ago, and it came about due to an investigation into other issues that I was experiencing. The alarm was raised because a very clever radiologist, who I thought was going to sign me off as well after a stroke that I'd had through other issues, found some unusual blood flows, and then looked a bit closely and found some unusual lymph nodes. However, Paolo touched on early some of the tests that are routine in diagnosing a CLL patient, and part of that is making sure you're in the hands of a hematologist. Unfortunately, I wasn't. So I think I had every test known to man to rule out possible other infectious complications and other issues, which went on for 6 months. So those incorrect tests caused a lot of anxiety, a lot of worry. Diagnosis went on for 6 months, when really a simple blood test would have actually sorted that out. So that's a precursor to actually being diagnosed. It took 6 months to be diagnosed. We've seen this cartoon earlier today, actually. I think Lorna put that up on a slide. To me, CLL still does today mean confusion, different levels of confusion. So once I was in the hands of a hematologist, quite rightly, immediately I was tested with flow cytometry, immunophenotyping for the other name, and my beta-2 microglobulin levels were checked, and voila, instant diagnosis. I had CLL, chronic lymphocytic leukemia. What is that? Yeah, that's when the journey began. So how many people, how many patients have actually heard CLL before they have a diagnosis of CLL? And straight away there became uncertainty, because I was told, as Paolo said, watch and wait. You've got cancer, you've got leukemia, we're not going to do anything about it. As Paolo says, go home, and should it develop, you may need treatment, but you may not need treatment for a long time. Should it not need, it just all seemed a bit intuitive. So the key thing I just wanted to highlight here, mirroring from what Paolo says, at this stage in a patient's journey, the most important thing I think is information, is making sure patients are provided with appropriate and timely information, and that's something that we as advocates can make sure, because there isn't really much more that can be done. If you are on watch and wait, which is important, there needs to be time for your physician to monitor over time how your disease is progressing. Then there is something required perhaps to relieve some of the emotional and psychological anxiety that causes. We touched on it earlier. We are all different. Heterogeneity, that was the name that was mentioned earlier. That was the first big word that I ever heard since I was diagnosed with CLL. We're all different, but how different? Yeah? Is CLL different? I heard that. Oh, you might have a different type of CLL. What do you mean there's lots of types of CLL? Apparently, we now know there are many types of CLL, but essentially a few. So the big question I ask as a patient at that moment in time, what type do I have? So I, as a patient, wanted some predictions about my life. I'm not a young person, but in CLL terms I am. My kids were still at preschool. Are there tests available? Are they reliable? Will they tell me anything of benefit before I need treatment? Will I require treatment? How long will I survive? I mean, these are the questions that we all ask, but you don't get any answers, because at that moment in time, there were indicators, but they were vague because there's no time served on watch and wait being monitored. So as I said, not enough time on watch and wait. Life diagnosis just meant questions, it meant uncertainty, it meant worry. Yeah? And I've got to admit, you talked about clinicians worrying. At this stage, clinicians don't worry. Patients worry. Yeah? Later on, clinicians start worrying. And I was a worrier. I didn't handle diagnosis very well. So, however, I had another issue going on with me. I didn't realise it, but I had heart disease. And what happened was that when I was diagnosed with CLL, everybody went leukemia, cancer. Let's go and look over here. They stopped actually looking at what the problem was. So I had a lot of physiological concerns. I had heavy symptoms, heavy B symptoms. And I wanted answers, and I did kind of pressure myself, in a way. I had a bone marrow biopsy, a CT scan, and a FISH early on to get some answers. But how useful were they to me? None. In the long run, none. Apart from one thing. Paolo touched on that. They stopped me being treated too soon because they answered the questions that it wasn't the CLL causing these issues. They actually directed it to where the real issue was, which was actually an underlying heart disease. But I found out that I had trisomy 12. What did that mean? Well, on Paolo's slides there, it did actually show some overall survival indicators. So it gave me an idea. It told me that I had intermediate CLL. What the hell does that mean? Yeah? No use to me whatsoever. In fact, as an avid researcher, I found out that there are other mutations that trisomy 12s might have, like Notch1, which has a really poor outcome, and they're found in trisomy 12. So actually, it just scared the hell out of me. Yeah? My nodal involvement was widespread, but it wasn't of pathological concern. I had tiny lymph nodes. That's the wrong thing for a bloke to say, but I did. Yeah? And I only had 40% diffuse bone marrow involvement. Now, as a patient, 40% involvement? What? I've got 40% cancer in my... It's nothing. It's diffuse. You think about a leukemia, you think about... these lymphocytes are able to travel around your body, so it's a diffuse disease. They're everywhere. They just happen to be everywhere in the bone marrow at that time, but only 40%, so that's really low, but I didn't know that. And the other great thing was, over time, I began to notice that the ALC, my absolute lymphocyte count, was climbing very slowly, yeah? And my other cell counts were normal. My hemoglobin levels were normal, my platelet levels were normal. So, I was now diagnosed and staged as I had early CLL with a stable progression, so that was reassuring. So I did get some benefits out of all of these tests, so I'm not sure if they were a total waste. This cartoon kind of sums it up really, because I'm not sure if you ever get any answers. Learning about CLL, my disease characteristics and some prognostic indications did improve my day-to-day quality of life. I was reassured that I had some indication of where my life, I had children at school. I realised at the time I didn't have to panic. So it did remove some of the uncertainties, but it really didn't give me an overall picture. Now, 7 years went by where you live with a developing symptom burden. Over time, CLL became my friend, if I'm honest. I got used to living with the challenges of the increasing symptoms. It's not easy. The psychological burden's hard. The burden on your family is hard. The burden on your relationship's hard. But my treatment was triggered looking at my absolute lymphocyte count was not high. Professor Gear says he never treats on counts alone. And I was treated because of my bone marrow involvement and because of cytopenias. My hemoglobin levels had dropped steadily from 350 down to 90, so it had triggered a bit of concern. And, my platelets, and my HB was down to 10, which is, as the professor just confirmed, is when clinicians actually stand. So we were talking about who my clinician was earlier. I think he had the right idea. Yeah? My bone marrow at that stage was compacted. It was 85% infiltrated and compacted. I'd found out that's the word. Once it's compacted, it means there's not much room for anything else to go on in the bone marrow. So your other cell lines start getting squeezed out. And I had very uncomfortable B symptoms. I mean, I think patients around here that's, Professor Gear touched on night sweats. Night sweats are drenching. You need to change the mattress, let alone the bed sheets. Yeah. Fatigue, bone pain, you know, they were pretty poor. So the predictive tests, as we were talking about, fish, so these are the tests I had at treatment that made it go. Fish had to be repeated anyway. I had it before. It was a waste of time me having it because CLL, as I said earlier, is a evolving disease. If I was a trisomy 12 halfway through watch and wait, I could have just as easily developed a clone that was 17p or had a TP53 mutation. So trisomy 12 is automatically repeated. And great, that remained unchanged. And I also received, thankfully in the UK now, you'll be glad to learn, in Scotland it's been part of clinical guidelines. TP53 mutational testing started in Scotland. It's now part of the England guidelines, and through Anna Shu at Oxford, it's been provided to all clinicians to ensure that this is carried out before a test. And I had an IGVH status test through an unconventional route, but it was through a clinical trial, told me I was mutated. Now that did actually give me a lot of confidence, not just my clinician, because first line, what's available to a fit person who's suitable for chemoimmunotherapy, you have a choice of either FCR, or if you're not particularly fit, maybe bendamustine, rituximab. I frankly, as a young person, wanted to try and avoid that if I could, and maybe, you know, from a strategy point of view, see if I could get on a clinical trial and access to a novel therapy and maybe have that after. But it didn't work out that way. It was a randomized trial, and I drew FCR. But one of those tests gave me more confidence than anything else. The fact that my IGVH status was mutated, knowing that there is a significant population of mutated patients that are still in remission 10 to 12 years after treatment with FCR, gave me the confidence to actually, here we are, knowing my predictive prognostic indicators at treatment aided me to have proper discussion with my doctors to make the right treatment choice, and it helped me then cope with the side effects of FCR. I mean, FCR isn't just a stroll in the park, yeah? I wouldn't give it to anybody's dog, yeah? You know, I had a poor journey on FCR. I became cytopenic after round 1. I was neutropenic after round 1, and I was pancytopenic after round 2. So, but the fact that I was mutated gave me the confidence to actually endure that. Unfortunately, I'll let slip just before this that I wasn't able to tolerate FCR to the full extent, but I was an over-responder, so I had a good response and I developed a remission, and I'm only just now relapsing after 2 years from a remission with 2 cycles of FCR. It had to be stopped, Paolo, because I was blood transfusion dependent still 6 weeks after round 2. But it just led me to say to everybody else that as a patient's perspective, you know, prognostic indicators are not routinely available early to stratify patients to help inform us of our disease type and maybe give us an indication, yeah? So therefore, I think all steps should always be there to make sure patients are properly informed or given what information is available just to help them cope with the diagnosis and living. So I mirror what Paolo was saying there, that those tests aren't available, but some of the symptoms that patients are living and the emotional and psychological stress that they're dealing with really needs to be balanced by information. However, as a patient, predictive prognostic tests should always be available at treatment to determine treatment suitability and the best likely response. And we've identified, and I can confirm as a patient, exactly the same. But we've got some developing issues now coming in the landscape that I think we need to also look at. The treatment landscape is getting very complicated. It's getting very complicated for doctors. And I've learnt a new phrase. When I was first diagnosed with CLL, I used to say, because I was told to say it, that don't worry about treatment, don't think about treatment until treatment comes, and when treatment comes, just take whatever treatment's available, but the best that's available, because the disease is what it is, and this is the best way we have to treat it. And I question that as a patient now. I question that we should now be going into treatment thinking, when we go into treatment, think about the next treatment. Yeah? And therefore, it becomes really important that we need to start developing the dialogue to encourage discussion about long-term treatment strategies for CLL patients. Now, I can be biased as well because I've just relapsed. So fortunately, I did think about my next treatment when I went into it. And fortunately, through Access, there is another one available through routine commissioning. But it's also important, I think, from the point of view of sequencing therapies. It's almost like now doctors and patients are having to play a game of chess through clinical trials or through routine commissioning availability. You can access one therapy, but that might actually block you with a stalemate from the next appropriate therapy. So I'll just end this by saying there seems to be a lot of variation across countries to access to testing. And it's a massive privilege to have been able to follow up with a brief patient conversation after Professor Gear, because it is his organisation and his leadership that is helping drive change to make sure that there is a spread of even-handed delivery of this across all countries. So thank you very much, everybody.
Thank you. Yeah.